Hello everyone, welcome back to Nursing Guru. Are you appearing for the mental health nursing practical examination? Here is a solution for you. I am here with a video of mental health assessment. So, shall we start? This assessment is helpful for the students of BSc Nursing as well as GNM Nursing. This also it is helpful for the PBPSc Nursing as they are doing the psychiatric assessment in the clinical area. So what are the assessment includes? Psychiatric nursing includes mental status examination, mini mental status examination, neurological examination, as well as the psychological test and some laboratory investigation. So we'll see first about the history collection. What is mean by history collection? Every nursing we need the history collection. So first we are going to discuss about the history collection, but we have to remember as we are doing the history collection, we also do the mental status examination. Sometime we do the mini mental status examination. So mini mental status examination is not required for all the patients, especially we are doing the mini mental status examination for those people whom we think the cognition level is low. Maybe we are doing the mental retardation patient, we are doing the mini mental status examination because it is no, we cannot assess other aspect of mental status examination. Okay, so history collection, first we have to see about the identification data, normal identification data, whatever the necessary things we are collecting, the name of the patient, age, religion, what is the family income, is there any other kind of aspect that is related to the identification, maybe the IP number or maybe what time they have come, date of admission. These are the normal identification data. Then we are going to see about the chief complaint. Now chief complaint means why they are being come to this hospital or what is the reason for the admission. So chief complaints are signs and symptoms. Maybe they may be having the hallucinatory behavior, maybe they are having the violent behavior, that's why they are brought to the hospital, or they are not taking the medication. So that may be the chief complaint, and we have to, whenever we have to tell the chief complaint, we have to tell the episodes, duration and how long time this chief complaint was present. That is what we are going to say about the in chief complaint. Maybe precipitating factor also we can include in the chief complaint. Next we are going to see about the present psychiatric illness. Present psychiatric illness includes all the chief complaint what we have discussed just now, and also the other factors. Maybe just before coming 2-3 weeks before coming to the hospital, what and all their chief complaint or the symptoms they had present, with the duration we have to tell, onset we have to tell, mode of onset we are telling, duration, intensity, also other precipitating factors we have to tell. So we have to collect the complete present chief complaints, that is called as present psychiatric illness or the psychiatric history. Then we are going for the past psychiatric history. So past psychiatric history and past medical history also we are going to deal with it. Past psychiatric history, before coming to the hospital, how long time these symptoms were present, whether they were known case of psychiatry or is it the first time they are coming to the hospital for the psychiatric issues. Okay, and was there any precipitating factor means any symptoms which increases due to certain stimuli, that is called as precipitating factors. So we have to see whether is there any precipitating factors. Also we have to collect the if they are already known case of psychiatry means whether they are continuing the medication or stop the medication. If they have stopped the medication, then we have to tell why they have stopped the medication. Then we are also taking the other medical histories. What are the other medical history we are taking? Is there a presence of any epilepsy was present or any surgery they have undergone, accidents, recent accidents. These are all the past past medical history. So next we are going to see about the family history. Family history means there are mainly two things will come. First one is family history of complete family history. We are going to take about the any family people are having same problem in their family. So family history we have to take 3 generation of family history we are going to collect in the psychiatry, because we have to, because the genetic precipitating factors will be there, means genetic influence will be there. That's why we need to take the 3 generation history. So in the 3 generation history, in order to understand that, we need genogram. We call it as sometimes genogram or we call it as family tree. Okay, so who are there in the family? Now patient is there means patient for whom they are married, that family also we have to take. Along with that, their parents' families also we have to take. So 3 generation history we have to collect it, and we are going to see is there any connection of the psychiatric problems are there for this present patient. Okay, that is family genogram. Then also we can find out any other known history in the psychiatric history in the family also we can collect it. So then we are going to see about the personal history. What do you mean by personal history? Is belong to only the person of the psychiatric person who has come to the admission, or who has come in the, who is staying in the wards. Okay, so in this personal history, first one we are going to see about the perinatal history. Perinatal history includes antenatal, during the childbirth, and postnatal. So antenatal means the patient's mother. We are not speaking about the patient mother had any complication during the time of antenatal, maybe placenta previa, or maybe hypertension during the pregnancy, or diabetic mellitus, or maybe any toxics, they are exposed to some toxicity, or maybe radiation. All that we can collect it. Also we have to see whether they were going for the antenatal visit, they have taken the nutritious food, all that we have to take it. Also we are going to see about the childbirth. During the childbirth, the child during the birth time, whether the mother had any complication during the childbirth, and the infant or the neonate undergone any complication, like maybe cord prolapse. That means the cord will be triangling over the neck of the baby or the fetus or the neonates. It can be one of the complication, or they had an instrumental delivery or vacuum delivery. This also can be. Then APGAR scoring. How was the APGAR scoring? Sometimes we may not get the proper history, but as much as possible we have to collect the history. Then we are going to see about the postnatal. During the time of postnatal, is there any infection to the babies? More than the mother, we are going to see about the babies. That means the patient, when the patient was a neonate or the infant, whether there was any infection, any injury has happened, especially the birth injuries can be happening, or maybe the accident. This also we have to collect. This all includes about the postnatal. Then we are going to move about the childhood history, play history, educational history. So childhood, play, education together we are collecting it, not separately. So whether who was the primary caregiver? Maybe the mother sometime may not be the mother, some grandmothers will be there, or whether they may not be having the parents at all, they may be brought up in the some orphanage and all, that can be also. So who was the primary caregiver? Then is there any infection, developmental milestone, we have to check it, whether how they have achieved their milestone. If they are having the primary caregiver, surely we will come to know developmental milestone. Then we also check about their education, was there any phobia they had during the time when they are going for the education, means the schooling's time. So as they were going for the primary school, and was there any phobia was present, or any abnormalities, like they had any abuses during the education time. Then also how was their play, whether they are having a solitary play, whether they are able to mingle with everybody, or they were not happy with the play, they were isolated from themselves, from among the group. All that is we are collecting. Also we have to see about during the education time, we also to see the adolescents who are addicted to habits, some abnormal substance abuses, maybe smoking, maybe this one alcoholism or drug addicts. Also this one running away from the schools, running away from the homes, or stopping the education, abruptly stopping the education or not going to the school. This all the history have to be collected. That is comes under childhood, play as well as education. Together we are collecting. Then we are going to see about the obstetrical history and the marital history. So marital history and obstetrical history we are collecting together. Make sure they are married and they are having some birth and all, childbirth. And all. If the adolescents are coming, means we don't need the obstetrical history. That we have to make sure for whom you are going to collect that history. So sorry, before that we also see about the puberty also. So puberty, obstetrical and marital we are going to deal together. Now when you are taking the puberty history, we are collecting mainly for the female, Male, very rarely we are collecting. If they are in transgenders only, we are collecting the puberty history. Okay, during the puberty only the changes will happen. That's why we have to collect for the transgenders. Otherwise, for male, we are not asking about the male any puberty history for the other as well as the obstetrical history. So female only we are focusing the puberty. So at what age they have attained the menarche? Was there any phobia due to the menarche, as well as how was the cycle, period cycle, whether it is a normal or some abnormality was present, okay, some complication during that, this dysmenorrhea or this any other conditions were present, abnormal bleeding was present, that and all we have to collect them. Okay, what was their reaction towards their menarche? That is also very, very important, whether they were accepting that they are female and they are okay with that, the menarche, that is also very important to take down the history. Then we are taking the marital history. During the marital history, at what age they have got married, how was their marital relationship, sexuality, as well as we are taking about their faithfulness to their couples or any extramarital relationship. Pregnancy we are collecting, if the mother is if a patient is pregnant, we are collecting the LMP, last menstrual period date will be collecting. Also we are collecting how many children gestation, how many deliveries have happened, birth, then how many was the miscarriage, any this one, what is that, medical termination of pregnancy was done, that also we will be collecting in the obstetrical history. Also, how was their reaction towards their pregnancy, also we are important to take down that history also. Means usually if the mothers, if a patient is having the postnatal depression, postnatal psychosis, they are at the high risk of developing the psychiatric problem in the later stages. That's why we have to collect those history also. Next we are going to see about the very important aspect, that is predominant history or premorbidity, not dominant, premorbid history. What is premorbid history? Premorbid history includes how was their relationship with the others, okay, and how they are usually, how they are looking. Maybe they may be introvert, they may be extrovert. That is their main, the personality. Also how their relationship with one another, with their family members along with outsiders, that is also is different. Sometimes family members they are okay, but outsiders they are not okay. So that is also we have to collect. Then any usual pattern of life, like what is their habits are there, how they may maintain their leisure time. Leisure time is free time, whether they watch movies, TV, outing, picnic, all that is we have to collect it, or they remain by themselves, leisure, use of their leisure time. Then how they are spending their time when they want to do any hobbies are there, like make a drawing, painting, music, any hobbies are there, miss, that also we have to collect. Then also we are collecting about substance abuse disorders, whether they are addicted to substances like alcoholism, drug, tobacco chewing or tobacco smoking, all that is we have to collect it. What is the predominant mood they are having all the time, what they are having type of. So usually sometimes they will be having irritability, sometimes they will be very happy. Predominant means premorbid, in the premorbid what is a predominant mood, okay, before the onset of disease what was their mood, that we are collecting. Also we are collecting the other history, like how was the sleep pattern, how is the this one defecation and urination pattern, and how is the nutrition pattern. This also we will be collecting. That is all comes under the premorbid history. Before the onset of disease, what was their condition, that is called as premorbid history. So this is all included as a history collection. So in the history collection, during when we are doing the history collection, we are also doing the mental status examination. So it is not a separately we are doing, when we are thinking about the medical surgical, you collect the history, then completely you are doing the head to foot assessment. So from the beginning, you are part by part you are doing the head to foot assessment. Whereas in psychiatric, it is not like that. It is together you are doing, or we are doing simultaneously. So far we have discussed about the history collection. Now we will go for the mental status examination. As I said, history collection, mental status examination or any other psychological test, it will go hand in hand or simultaneously. So mental status examination has 7 components. What are those 7 components and why it is needed to know? Okay, first component is general appearance and behavior. The second component is speech. Third one is mood. Fourth is thought. fifth is perception, sixth is cognition or the cognitive function, and the last one is insight. Okay, so one step by step we will see what it is, but we are not going to do the assessment step by step. We do simultaneously. Only except cognitive assessment or cognitive function test we are doing separately, and in that also some of the things we can do it simultaneously along with the history collection during the time of history collection along with the other assessment. Okay, so in the general appearance and behavior, what we are going to see. General appearance and behavior we are seeing about, first one is appearance, how they look. Okay, so the look can be, sometimes the patient will be looking okay, means for their age, according to their age they look okay, but there are patients, especially in psychiatric patient, they look very old when they compare to the actual age. So that is we have to appearance, means that we have to see. Also we are speaking about their, whether they are undernourished, malnourished, obese, that is also looks like the appearance. Then we are speaking about the facial expression. So facial expression is about whether they are anxious, fearful, smile, pleasant nature is there, that is also facial expression. We are also seeing about the level of grooming and cleanliness. So sometime mania patient and schizophrenia, especially the simple schizophrenia patient and mania patient, they are having high grooming level, means the over grooming, not high grooming, over grooming, they dress up too much. Okay, when it compared to the depressive patient, they don't dress up, they don't maintain cleanliness. For that, cleanliness will be not having any changes with the mania or the depression patient, but grooming is differences. Okay, so grooming will be high or over grooming will be there in the mania patient, whereas depression no grooming, they don't comb their hair, they okay with the whatever the dress is wearing, like that. So you have to see the level of grooming, is it normal, it is over or under, that is you have to see. Under the cleanliness also, how is their cleanliness, their cleanliness is maintained or not. Then we are also seeing the mode of entry. What is this mode of entry, how they are brought to the hospital. So mental status examination, though nurses are not doing separately or we are not doing conducting, the nurses who are there in the those who are taking care of the patient, we are not doing separately, but as a psychiatric nurse, as I am studying the psychiatric nursing, I should know how that is done. So mode of entry also is very important to understand. Is a mode of entry means how they are brought. Okay, whether they are brought forcefully, whether they are tied up and brought. Usually violent patients and all, they will be tying up and they will be bringing. So how they are brought forcefully or tie up, or they walked and come. Okay, that is mode of entry.